Hello, 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 everyone. Welcome to the ABLE International Overdose Awareness Day webinar. Thank you for joining us today. We are so grateful to have you with us. I will start right away while people are still joining in, just to make sure that we are on time and that we have time at the end for your questions. I am John. I'm the CEO of ABLE, and I will be chairing today. Just to let you know that the session is recorded. But none of your faces will be shown, only the faces of the panelists today when we share the recording with everyone at the end. If you haven't joined our newsletter, make sure to do so, because that's the list that we use to send the recording to. And you can find that on our ABLE webpage. Also today, if you need some closed captions, there is an icon at the bottom of your screen with two big C's that you can click on to make sure you get the closed caption. We could only choose one language, so we put it in English today. Hopefully that's going to be okay for everyone. But if you need a transcript in a different language, just make sure to write us an email at info@able.org.au. So I'm going to start by some acknowledgement of country today, of course. So ABLE acknowledges the traditional custodian of the land on which we live and work, and the lands from where you are all coming from today, joining us online. We pay our profound respects to elder past and present, and extend it to all Aboriginal and Torres Strait Islander people with us online today. I'm coming to you from Gadigal land, and the land here was never ceded, always was and always will be Aboriginal land. I also want to take a second to do an acknowledgement of community today. Of all day, it is crucial. So ABLE acknowledges the legacy of the peers who went before us and those who continue to strive for equity and social justice in the face of criminalization. We reaffirm our commitment to work alongside our community, challenge stigma and discrimination in all their manifestation. So today, as you know, it is a day that can bring a lot of emotions. So if during the webinar you need to take a pause, I invite you to do so. And if you don't feel well, please make sure to reach out to a peer or to one of our drug user organizations if you need any support. Unfortunately, we are online, so it's a bit harder to do it this time, but you can also reach ABLE by phone or by email if you need. So we have amazing presenters today. It's really incredible that they were able to make the time to join us. I feel very grateful that they are taking time of their days to present in this beautiful webinar. And the first presenter we have is someone that means a lot to ABLE, means a lot to me, an incredible board member of ABLE, but also the CEO of Harm Reduction Victoria. Sione is just so well known because he has worked for 3 of the different ABLE member organizations in various roles, including policy, advocacy, community development, and health promotion. Sione is a gem. He is currently the CEO of Harm Reduction Victoria, supports ABLE on so many different levels. And Sione is speaking today about the current landscape of Australia in relation to naloxone and overdose. To you, Sione.
Thank you. Thank you for that introduction, John. That was very sweet. I've got some slides I'm going to present from, and I'll probably look across to them a little bit too as we go along. So I hope you can all see that now. If not, let me know, John. So yeah, I'm going to focus in on, as John said, my name's Sione. I'm the CEO of Harm Reduction Victoria, but also a board member, and really proud to have also worked at Karma and Newer. And both of those organisations are going to come up in this presentation a little bit. So I'm going to go through primarily focused on peer-led take-home naloxone programs and what that's meant for us and where we're going with that. But and I know there'll be other presentations about the naloxone, the national naloxone program, and I'll touch on that a little bit as well. First of all, I'd like to acknowledge as well, recognise and respect ancestors, elders and families of the Wurundjeri people of the Kulin Nation, who are the traditional custodians of the lands that I'm on today. And this land its sovereignty was never ceded, and I'd like to acknowledge that we're on stolen land. And I thank you for your acknowledgement as well, John, to the community. And I'd actually like to kick off, although we're talking about naloxone, to really just remind everyone, as John said already, that it's International Overdose Awareness Day time, the end of August. And that's a day that's really important and has gained a lot of traction over the past few years. And it is a really important day for raising awareness about overdose and the impact that that's had. But I think, it's worth remembering that for the affected community, our friends and family in particular, this is a time of year where we get asked to be part of many events and many awareness raising activities, and that's great. But at the same time, that can be a lot of labor, emotional labor, but also just straight up labor. And we're happy to do that, but it's also something, this focus on overdose and therefore by sort of extension death is not necessarily the approach that we would all take. Always, there have been remembrance ceremonies at different times, but we also have an International Drug Users Day on November 1. And ABLE has its regular meeting every year as well, where we try to celebrate as well the amazing work of people who are affected by drug use, people who use drugs, drug users, and all the work that we've done as well. So I just thought I'd start by just putting up on the screen an amazing piece of art and a quote, which is from a report done by Quiver in the Griffith University. So Tim and Emma are the people that I know who are part of this. I'd like to acknowledge this document, Voices of Lived Experience, Understanding Overdose Narratives Among People Who Use Drugs in Queensland. And I think it's a fantastic piece of work, sobering, of course, but it really sort of speaks to some of the complexity and some of the issues that we as a community sort of wrestle with when it comes to overdose. I'm not going to have time to go through that completely today, but I just wanted to call it out, and there'll be a QR code at the end as well. And I really recommend sort of you looking at that, taking that QR code or going to the Quiver website and finding this. The quote there is the quote that's on the screen is, "I'm holding a lock of my brother's hair contained in a small plastic box with a clear lid given to me by the funeral home. While we all expected my brother to die young due to his drug use and general reckless lifestyle, I was still not fully prepared within myself for the many layers of grief that accompanied his death." And for many of us who have lost really close friends and family, this is something that would resonate really strongly. And really, I think we need to remember that underneath overdose is the thing that's driving it, is the thing that's driving the overdose rates primarily, or one of the major things driving overdose rates, is people overdosing without a witness. And I know that one of my close friends who overdosed was actually died in a room when there were people in the room next door. And he certainly didn't feel like he was able to tell those people what he was about to do. And as a result, there was no one there to give him naloxone, which is what we're talking about today. So stigma drives people to use in isolation and in alleyways and bedrooms, and people feel like they can't be honest. And it's partly because once someone knows that you're a drug user, that almost becomes everything about you. And this quote, I think, sums that up beautifully. And for me, it was about realizing how much, once you have that label, all the other amazing labels you have become less. So she was a woman, she was a partner, she was a mother, she was all these things. But when the health system saw her, they saw a drug user. And having that happen to us over and over again is one of the leading drivers of overdose, in my opinion. And I think it's fairly clear through the evidence as well. Naloxone is fantastic and it saves lives, but it can't fix stigma by itself. Like, we always need people-centered approaches augmented by medications like naloxone, and not the other way around. However, I'm here to talk a bit more about the history and what's going on with naloxone. I just wanted to really flag the fact that CARMA in the ACT, which is the ACT peer-based organization, really led the way. And Chris Goff is leading that organization now. I also used to work there, and wanted to call out Dave Baxter and Nicole Wiggins in particular for really pushing peer-led responses to overdose and take-home naloxone. And it was the first jurisdiction in Australia that enabled peers to train our community, and then also really importantly get naloxone into their hands. And you know, there was a whole process that went around that, and a really important evaluation led by Anna Olsen, I think it might be in this audience, which showed that it's perfectly safe for the community to train and administer naloxone, and this commenced back in 2012. There's some information there about the participation and so on, but what's important to know is that all the reversals were successful in this case. And one of the really important things that came out of this, though, was that the program also had really important positive emotional impacts for participants. And I think that that's one of the key strengths of a take-home naloxone program, is it empowers people who are traditionally often disempowered structurally by systemic responses. After that, after CARMA led the way, other jurisdictions dominoed, and naloxone became available in different ways. They weren't all peer-based initially. Certainly in Victoria they were. I know that in WA they certainly were as well. But now as I'll come to later on, we do have peer-based programs in most of the jurisdictions, and naloxone's available nearly everywhere. I'll come back to that later. But take-home naloxone is incredibly effective, and we all know that. There's also a national naloxone reference group. So essentially, I think there'll be someone from the Commonwealth talking about the program. So the funded program at the Commonwealth level is really important in providing the medications and providing a system for ordering it. And then the states and jurisdictions have done different sort of approaches to making it available since it became available on the PBS a couple of years ago. But even prior to that, naloxone has been out in the community. And I think peer-based organizations have been really important in that, in leading the way on that. And one of the reasons is that I know that certainly Jane Dicker, who pioneered Harm Reduction Victoria's Overdose project, she's always been really strong about making sure that naloxone gets into people's hands. If we're training them, we've got to let them leave with naloxone. So these first responder type training programs have been going on for ages. And this is just a summary, and apologies if any of the information on this is not completely accurate now. I know it's a slightly older slide, but essentially what it shows is that there's a take-home naloxone program in some way or shape or form in each of the states or jurisdictions, I should say. And I've just highlighted the fact that there are peer-based programs in most, but not all the jurisdictions, sadly, although I know that there are some fantastic peers in Tasmania who I'm sure will be working on this. And if I got that wrong, I apologise. Also, you can see over here the sort of syringe arrows, needle and syringe program arrows, sorry, that a really key part of the take-home naloxone now is also it being available through NSPs. But there are multiple ways for naloxone to be made available. That can include on release from prison, which is something that doesn't happen quite as often. And I think it's also obviously the pharmacies are also places that we can get take-home naloxone now as well, thanks to the Commonwealth program. So the Victorian program, for instance, is there are multiple ways to get access, but one of them is through needle and syringe programs. So they become approved outlets. They do a brief intervention with people coming in and are able to give out at least two doses of naloxone, whether it's Nixoid. At the moment, we're also giving out other types as well. And in Victoria in particular, we're also there is peer-to-peer distribution as well being made legal. So where we are now, as I've already said, really is that the Commonwealth PBS availability is a crucial baseline, but we've all gone about it a little bit differently. I've talked about the Victorian approach. Sadly, the registration on the pharmacy registration is not always equaling provision in our experience. So we've done ring arounds of pharmacies who are actually registered, but they're not always able to tell us whether they have naloxone or perhaps they don't have naloxone and they're not, they might have registered, but they're not actually participating at the moment. And that's probably something that we want to work on over the years, as we go forwards. And I've actually put a screenshot from the website Ozbargain where someone has just, I'm not sure, I genuinely don't know who this was, has decided to put up the fact that you can get take-home naloxone from participating community pharmacies, and it is indeed a bargain. And they put that up on the website. And although, there's been some pretty crappy comments, it is pretty good kind of information shared as well. And that's a pretty innovative way of sharing information about the program. But generally speaking, these programs are promoted through needle and syringe programs and peer-based organisations like ours. There was actually a question that was sent in advance that I just wanted to speak to you quickly as well, which is that the provision of naloxone to community is pretty well sorted in many of the states, but that's a little bit different to workers or harm reduction workers or peer workers who are currently working, being able to administer naloxone and making a decision about that when they come across an overdose. I probably don't have time to go into all the details, but in Victoria, one of the issues is that medical indemnity insurance doesn't necessarily cover a harm reduction worker from using naloxone whilst they're at work. On the other hand, for the community or civilians or people who are not working at the time, our Good Samaritan legislation covers us in the case of an adverse event, but that's not the case when people are working. We're working to resolve that in Victoria, but I know that that's an issue for some of the jurisdictions and perhaps not all of them. So in summary, the combined peer-led programs have delivered tens of thousands of naloxone trainings. As I said, we generally don't need anyone to leave without naloxone, but there are still issues in harmonising the regulations across the country. It's much easier now, and that's got a lot to do with the Commonwealth program. And most jurisdictions usually have multiple ways to access. I've talked about Victoria already, and the others have different approaches as well. Increasingly, postal programs are things that people are asking for, and that's really important for equity. The National Naloxone Reference Group has a subcommittee that's working on how we can ensure that can be done nationally. But NEWA, for instance, the New South Wales Youth and Aids Association and others have been posting naloxone for a little while, and NEWA in particular had their program evaluated, and that evaluation is really important to show that this is a safe way to do it as well. But as I kind of mentioned at the start, there'll always be overdoses until we destigmatize drug use and people who use drugs. And in my opinion, and in Harm Reduction Victoria's position is that we need to push through drug law reform and do that well before we can really address the stigma that attaches to people who use drugs, sadly. And that will be my final message for today. Well, actually, no, my very final message is thanks to the people whose slides I used today, including Penny Hill and Paul Dietz from the Burnett, and also Quiver, for the quotes and the research that I spoke to at the start, and that QR code is up there for you. But if it doesn't stay up there long enough to get that report, you can go to the Quiver website. And thanks very much for having me.
Thank you so much, Yuni. Thank you for this wonderful presentation. And there's so much to think about and to consider, and especially around peer workers being able to carry and use more than carry naloxone without having any legal repercussion. And that's something we should discuss a bit more at the end as well. And I have a lot of different comments on what has been discussed already, but I'll keep that for the end when we are answering some of the questions. But Jenny, you did mention in Tasmania, there's some really good peer-led efforts that are happening at the moment, and someone put in the chat to thank for her work and the president of Tasmania. So I just wanted to echo that as well. But I'll jump right away to our second speaker, so we'll have some time at the end for the questions. But our second speaker is Joanna Canado, and Joanna has been for the past few years coordinating actions through your input, the European network of people who use drugs in Europe, and especially for support Don't Punish International Overdose Awareness Day. I had the chance to see Joanna speak at the Input Community Day in Geneva, and she was amazing, and we wanted to make sure to have her today to discuss the incredible work that is happening in Portugal, especially around the distribution of naloxone, the use of naloxone, and in the EU as well, and present a case study. So thank you so much, Joanna, for joining us in the middle of the night for you.
Thanks for the invitation and for the introduction. Yes, it's around 3:50 a.m. over here. I'm happy to be with you. So before starting to introduce the Portuguese reality on the naloxone distribution and general landscape, I would like to make sure that we agree on a few points. Here, there is no national take-home naloxone program, but still we do it. It's always depending on political willingness to have available naloxone and community-led distribution, and also it depends on NGO based know-how on the importance of peers for this distribution, and basically NGO are responsible also for fostering peer-led training and peer-led distribution. The campaigns help a lot to gather specific moments where people get trained and get overdose stock for then having in open drug consumption settings, informal drug consumption rooms, and other sites that we know that at night, especially when there is anyone in the streets, and when people gather together also to use drugs, we need to have naloxone available in these specific moments. And that's what we make sure that peers and specific, let's say community leaders have the opportunity to get stock for the community. And yes, now I will tell you a story because basically, we here although we don't have a specific take-home naloxone program, within the first drug consumption mobile program that was born in 2019, we got let's say a budget to work with peers. So I was working in Barcelona by the time, and I should mention that Barcelona has a widespread naloxone program. We thought that maybe one of the things as a community organizer would be to train peers, and especially let's say the users of the service and my comrades to get naloxone. This was seen as maybe not so easy move, because we had this until that moment we have this specific know-how that only the nurses or the doctors could introduce naloxone or give it out within a specific setting, let's say a drug consumption room. But we all understood that the moment that was actually then COVID and with the pandemics, that people were getting more alone in the streets, and that there were also a rise on overdose number in 2019, and we started thinking, okay, we need to budget this. If we don't get the medicines from the governments, we should actually budget it within the medicines of the safer consumption program and get it distributed. We did have first huge distribution from CICAD, which is the ICAD right now, the Drugs Institute, but the naloxone was already expired. It was Nixoid, and even if the pharma behind the medicine told us that 6 months of expired naloxone would be good for still distributing it. When we got the naloxone, it was already expired, and 6 months had passed. So when it was the International Overdose Awareness Day, we did a huge in 2020. We did a huge training, and in a specific open setting of consumption, we distribute like, let's say, unofficially loads of naloxones, and we got trained people also on the drug mixes and the dangers of consuming certain drugs apart from opioids, because we all know that when we talk about overdose, it's not only about opioids. Naloxone is the medicine for reverts an overdose with the opioids, but also you should address other drugs such as stimulants overdose or GHB overdose, ketamine overdose. So we start doing this training collaborative between peers, and the know-how and by the experience that we know is the first one we need also for demystifying some myths around the drug use in general, and also with the help of nurses. So this was the first action to take in 2020. And from that point, I think the action ran very smoothly and well. Me as a community organizer as well, I start having some naloxones to distribute. Specifically at night, I would do with one of my peer colleagues, let's say a feminist brigade, like go out in the streets and go to the informal settings of consumption, also because we use drugs as well. So we would go, we would help to make the spaces safer and to get naloxone to the community. I can say that this has changed a lot at micro level, the well-being of people who use drugs in the city of Lisbon, because the naloxone is nowadays with anyone. And this is an important step, to keep our community safe. I think the most important step, because as I said, it's not always overdose doesn't happen only in drug consumption sites. And overdose can happen anywhere. It can happen even in the streets, and you can see someone down. And if you have a naloxone, and if you find out by the signals if that it is an overdose, and you have naloxone, you can bring the person to life. And we know that sometimes the emergency takes some time to get in action. We know that sometimes people use drugs. My comrades are afraid to recall on the police or the emergency, because the police can come with the ambulance. So to overcome all this, if we get naloxone, it's a way to make sure that people stay alive. I would like also to introduce you a technical brief by Heroin Pools. I'm putting here on the chat, okay? Because mostly we have done this effort to gather the best practices around the world, and Portugal is also here included as a case study led by the community. And you can find some data over here. Basically, we address 3 specific points as successful practices. Is that peer innovation during the pandemics definitely led for more people use drugs, get to know more about naloxone, and to have that medicine with us all the time. Harm reduction teams are always requesting more naloxone. So, for instance, now we are already celebrating the International Overdose Awareness Day today with Manas. Manas is the collective of women using drugs I co-found in Lisbon, together with Magda and with the support of GAT, the Treatment Actions Group, which was actually the community-led organization that founded the first mobile consumption room. And that included peers from the beginning in the design, implementation, and delivery of the service, including the naloxone distribution, peer-to-peer distribution. We need to also have some policies sometimes that protect that whenever we don't have like the government support to get this medicine, that medicine is still available. Because what happened here is that fortunately we had also a collaboration with Doctor of the Worlds during the implementation of the peer program within the drug consumption site, that allowed us to have always the medicine available whenever it was needed to reinforce the stock. But we cannot counts always on the budgeting, because most of programs within harm reduction are under budgeting. So we really should have a policy of implementation of take-home naloxone programs widespread international territory. Also because Lisbon is a situation right now, for instance, 10 organizations got together to celebrate International Overdose Awareness Day. We are giving at least 2 trains every day, not only on opioids, but also other drugs, to make naloxone available. And when a team or a peer group doesn't have naloxone, we can get it from other services. And this is also a fluid communication, but this does not happen in other points of of Portugal, especially the rural part and the community. And I guess Australia might be similar in these situations, that the rural landscapes are always struggling more for getting innovative answers in the services. And naloxone is not innovative, let's say, but at least as a part of a constitutive service, and having in mind the quality of life of people who use drugs. So yeah, distribution might start from any community center. We don't need to be speaking about the drug consumption room specifically, because there is also lacking of this specific service around the country. Let's say that Porto and Lisbon, we got some drug consumption sites, but not in other parts of Portugal. We strongly recommend peer-to-peer training and distribution. Get peers trained is very easy, because we can get specific training in every substance and to address the mix of substances and safer consumption practice. But we can always have 10 minutes naloxone express training, I call it, or ninja training, for identify overdose signals and get people to use, for instance, Nixoid, because here we get mostly Nixoid to be distributed, which is pretty easy. It's here behind me in the image, in the nose, and very easy to applicate by anyone. So I hope I didn't miss so much information. I'm open to your questions, and yeah, let me know your thoughts and doubts. Thank you.
Thank you so much, Joanna. That was incredible, and so much learning that we can get from what you're doing in Portugal. And I really see the link between what we're trying to achieve here in Australia and the work of our organizations, but also the government that can really learn from what you're doing, but also an exchange, as you said, from the take-home naloxone program. So I see that as a very positive step forward to keep in touch and make sure that we can learn from each other and support each other. And I have some questions and I have some comments, but again, I'll keep that for the end, and I'll just have a look. I think the link, Molly reposted the link that you posted in the chat to make sure everyone could see that in the Q&A as well. So thank you for that. And thank you for sharing this document. It's incredible, and that's going to be very useful for us as well moving forward. I'm going to jump right ahead and move to our third presenter today, or panelist today, Colleen. Colleen is from the Australian government, the Department of Health and Aged Care. Colleen is the Assistant Director of the PBS Section 100 programs within the pharmacy branch of the Australian government, the Department of Health and Aged Care. Colleen manages the nationwide Take-Home Naloxone program, which she will discuss the challenges and opportunity in Australia. It's so amazing to get someone from the Commonwealth to come and present. We've been very lucky the past year in having some of you colleagues as well, and we're excited to have you, Colleen, and to hear about what you've been working on and how this has been evolving. Thank you for joining us.
Thank you, and thanks for inviting me. Appreciate the introduction. Appreciate it. I'm grateful to be here. I'll just share my screen so I can share my slides. Hopefully you can all see that. Okay, I'll wait to start. I assume you can see.
I don't think we can see your slides at this point. Perfect. We see your screen. Excellent.
Great. So firstly, thank you for that. So my name's Colleen Christophers. As John introduced me, I'm one of the assistant directors in the PBS Section 100 programs team at the Australian Government Department of Health and Aged Care. So there are multiple pharmaceutical benefits or PBS programs that our team manage to help provide access to medicines. And so one of these programs is the Take Home Naloxone program. And just before I begin, I'd like to acknowledge the traditional owners and custodians of the lands in which we meet today. I'm on Kaurna land and I pay my respects to elders past, present, and to also any Aboriginal and Torres Strait Islander peoples who may be joining the webinar today. So yes, thank you for the opportunity to present today. It's a great opportunity for us to raise awareness for the importance of naloxone in opioid overdose and for the THN program itself. So there are a few aspects of the THN program which I'll talk about today, which are listed on this slide. So these statistics, or the infographics on the screen, are from the recently released Pennington Institute annual overdose report for 2024. I won't go into all the specifics, as I'm sure quite a few of you have read this report, but you can all appreciate the impact opioid overdose has on Australians and the burden it has on mortality, with the rates of opioid-related deaths and hospitalisation increasing. And as you're all probably aware, there's increased concern in the community for synthetic opioids, which are entering the Australian market, particularly nitazines, being mixed with other substances, which are sometimes unknown to drug users. So yes, most people in this room would be aware of naloxone and how it works to temporarily reverse the effects of an opioid overdose or adverse reaction. But it's still important to remind people that they need to call an ambulance after administering naloxone, as a person can still overdose after 60 to 90 minutes after using naloxone. So prior to the THN program, naloxone was only available as an over-the-counter purchase, and this was privately from a pharmacy where the cost can range from approximately $30 to $50 a box, or you could have one box. So as an example, Nixoid subsidised on the PBS, where you'd have to go to your doctor, get a prescription, and you'd have to pay a co-payment of either $7.70 for a concession patient or $31.60 for a general patient. So we ran a pilot program in 3 states, New South Wales, South Australia and Western Australia, from 1 December 2019 to 30th of June 2022. The University of Queensland were engaged to conduct an evaluation of the pilot program, and the final report is available to read on our website. Some of the findings of the evaluation were that were used to inform a government decision to expand the pilot into a national ongoing program. The report used a mix of data collection activities, and some of the findings showed that consumer uptake was increased through a broader range of access sites. And we've also got some key statistics from the evaluation, which are these graphics on the slide, which I'd like to particularly point out the number of lives saved per day, which is 3 lives per day, which included improvement in both prognosis and reductions in mortality. So in the 2022-23 federal budget, $19.6 million over 4 years, and $4.9 million ongoing was committed to a national THN program. The national program commenced from the 1st of July 2022 for community and hospital pharmacies, and then later on the 1st of November to non-pharmacy sites, and these are known to the program as authorised alternative suppliers. The THN program makes naloxone available for free and without a prescription to anyone who may experience or witness an opioid overdose or adverse reaction by broadening the usual PBS subsidy and access arrangements. No Medicare details or other identifying data is collected when supplying naloxone through the program, and the intention for this is to increase access and reduce barriers to patients trying to access naloxone. So there are over 4,700 registered sites participating in the THN program at the moment. So I briefly touched on the slide before. Suppliers that can participate in the program are community and hospital pharmacies, medical practitioners who are approved to supply PBS benefits, and then non-pharmacy suppliers or the authorised alternative suppliers or AASs. And some examples of these are alcohol and other drug treatment services, needle and syringe program sites, and custodial release services. Usually the advice of a pharmacist is required to allow the supply of naloxone. However, there have been changes to legislation to enable supply of naloxone by providers other than pharmacists. So these arrangements have been removed to increase access to naloxone, which has been quite key in the expansion of the program. Approximately 90% of naloxone is still supplied through community pharmacies, but we still feel it's important to have these other non-pharmacy sites as access points. We've received a lot of feedback throughout the whole consultation process to say that people feel stigmatised when asking naloxone through community pharmacy at times, and having these other access points makes people feel safe when requesting naloxone. And so we're working with a lot of the states and territories to continue access to the number of AAS sites participating in the program. So this slide shows the formulations of naloxone available on the program. All of these are the naloxone formulations available in Australia. So we've got the three presentations: the nasal spray, the pre-filled syringe, and ampules. The nasal spray by far is the most popular formulation and accounts for over 80% of naloxone supplied through the program. So each box of Nixoid, as you may be aware, comes with 2 sprays in each box, so an individual can access 4 sprays in one supply. And there's currently a second brand of nasal spray which was temporarily approved on the program to fill a supply gap during a previous shortage, but this will be delisted from the program in the upcoming months, as it won't be available for distribution in Australia any longer. So individuals can be supplied 2 boxes of pre-filled syringes per supply, which has 5 doses per syringe. That will be 10 doses per supply. And that's also the same with the ampules, where 2 boxes can be given at once. And there's 5 ampules per box, leading to a total of 10 doses per supply. One of the requirements for suppliers to provide naloxone through the program is to provide data with each supply. This data is relatively simple, but helps us to see how and where naloxone obtained through the program is being used. An online portal is used to submit and collect the data, and for providers who are entitled to reimbursement, claims are paid through this portal as well. The data which is collected is on this slide. As I previously mentioned, there's no identifying information collected for the program to help improve accessibility to the program. Providing a reason for refill is not mandatory if the patient doesn't consent, but we do receive some useful information from this data, so we do encourage our suppliers to collect this information. And I've got some statistics on that on the next slide here. There's been over 408,000 units of naloxone supplied to Australians since the 1st of July, when the program expanded nationally. Where we did collect data, 85% of the supplies were initial or first use, or 15% of them were supplied as a refill. So there's 4 reasons that providers can, or that individuals can tell us why they're used, or why they're collecting the product as a refill. So either if it was lost or damaged or expired, given for someone else to keep, used on them or somebody else. You can see that 13% of the time it was used on the person, or 28% was used on someone else. So this equates to about 13,000 times where it had been used, and that's for just over a 2-year period, which is great to see that it's being used and hopefully saving some lives. We worked with the Australian College of Pharmacy to develop a range of training modules, and these are focused on pharmacists, patients and their carers, or healthcare or other AAS workers. These resources were developed in consultation with many of the stakeholders across all the states and territories. The education is not only for clinical updates for naloxone, but also encourages people to approach patients to open those conversations, as that can be quite difficult for some people. Pharmacist training module does provide continual professional development points, or CPD points, which is quite a bonus for us pharmacists. Resources and patient education leaflets have been developed with information about what opioids are, warning signs for naloxone, or how to administer naloxone, both in injectable and nasal spray forms. And I've got some examples of what these look like, and there's also a link here to where to access these to download. I know they're quite small. Maybe don't download them from the website. Thank you for your time today to listen to me speak about the program. There is more information available on our website, which the link's shown on the slide. There is a link. I've left a link here as well to the evaluation of the pilot program, and our email address if there's any questions you'd like to send through.
Thank you so much, Colleen. It's so good to hear how much naloxone was used to prevent overdose, and hopefully saved a lot of lives. Thank you for joining us and presenting on this. It's really such an amazing program. We're very lucky to have it in Australia, and we're happy to see that there's investment from the Commonwealth to keep on increasing this program or expanding this program to really make a difference for our community. As a community member, I have lived experience of overdose, and I guess what I would like to do next is I did ask to be put as one of the speakers today, because I think it's important to discuss advocacy as well, and especially considering the people that we've lost due to overdose and the report that just got out, and knowing that it went from 5 people a day dying of overdose to 6 people a day, which is absolutely unacceptable. I think we need a change, and we also need to talk about what needs to change and what we want to see. I think that is just a priority. It is great to see the take-home naloxone program expand. We need it, we want it, but there's other things that I think we really need as well. I think it's important to acknowledge that criminalization is ensuring in a way that we have toxic supply, and we have black markets, and people don't know what they're taking. We have some drug checking program. There is great momentum in Australia, and we see those popping in different states, but we definitely need some drug checking in every state, and we need some that are peer-led. We need to make sure that this is available for people, especially people that feel stigmatized, to access, to know what they're taking to prevent overdose. When it comes down to alcohol, we all know how a bar works. A bar is basically a peer-supervised alcohol consumption room, and we don't really have that on the drug front. We only have one center in one room here in Australia, but wouldn't we want to see some peer-based or peer-led drug consumption rooms that are more cost-effective, that can save lives? And I was at the event from Quiver in Queensland, where it was mentioned that no one died in a drug consumption room internationally, because often there's peers there, there's nurses there, there's the people that care and that want to make sure that overdoses are prevented. And I think that it's really important to have this as part of the conversation. It's like, is the government, is the Commonwealth will invest in making sure that we have some peer-led drug consumption across Australia to save lives and to prevent people, especially that are stigmatized, to die of overdose and in a room somewhere alone. I think that is an important part of the conversation as well. We had some questions that were sent to us prior to this webinar around naloxone, and some of them were around can naloxone be used for GHB. So we did some research, and at really high dose, it is potentially possible for naloxone to prevent a GHB drop, but it's not. The research are really conflicting. So honestly, we can't really endorse this as a solution at this point in time. That it would need more research. So just letting you know, this is what we discovered in our research, our third research quickly before the webinar. But we'll be sending more information to the people that asked about this. There's also a question around for trans people and queer people that are on hormone therapy, if that could affect this. We couldn't find any information about that. There's definitely a lack of research around naloxone and that kind of intersectionality. So unfortunately, it wasn't possible for us to answer that question. But we will send you what we found online. I think we now have some other questions as well. So we have someone who's asking, how did each state find out the data on how much naloxone is being distributed, what areas, and how many services are registered? This information would assist us in knowing what areas need more support to increase uptake. I don't know, Colleen, did you have a bit of information around that? It's a very precise and technical question, but if you have the information, that would be great.
Oh, geez, took me a moment to turn my camera on there. So this is the questions in the chat that you're looking at about the data.
Yes.
Yes, we're working on this at the moment, and I think we are working with some of the states to provide sort of this data to them. So this is still in train, and we're hoping to come with provide an outcome to that within a few weeks.
Thank you so much, Colleen, for your work on that. And you can let us know so we can send the information to the participants when that's ready. And we have another question for you in the chat that is asking, I think it's Liz asking, hi, Colleen, great that the government have expanded access to naloxone to AOD treatment, NSP services, and custodial release. Any plan to expand access to people in custodial services through custodial officers and health services?
Yes, I can answer that one. Custodial services are covered by states and territories, so we're not able to fund medicines for incarcerated persons. That's same with all PBS, with most PBS medicines. It would be the same funding arrangements for inpatients, but certainly for custodial release, the THN program can apply.
Thank you, Colleen, for highlighting that limitation there. I think there's definitely, I guess what is coming out of that is that for the community, it's really important to have kind of a whole of government, or at least a whole of department approach to those kind of situations to make sure naloxone is available, not only in pharmacy, but also in tons of other settings. You know, it could be available in schools, could be available in bars, could be available in prisons, could be available so many other places that could really make a difference and save lives. So I think that's what that question was highlighting, and especially around prisons, because we know that people may overdose there and not have access to naloxone. So we have some other comments here. So thank you, Aisha, for your support. And we also have someone saying, love all the speakers. And it's great to hear from Portugal. I must say, after the presentation from Joanna earlier, so I had the chance to visit the services of CAT in Portugal, and we actually did a report that we presented to the Commonwealth on how incredible and innovative and holistic the services were there. Even though there wasn't a take-home naloxone program, there was really that kind of peer-led, peer-supervised, and nurse-supported drug consumption room that also had a drop-in center where people could benefit from treatment and services and support and access to naloxone within those spaces, and how GAT was really proactive in its advocacy and working with the government and other organizations. I don't know if you want to speak a bit to that, Joanna. Like, I think it's just so inspiring to see what is coming out of Portugal and how you guys are just not stopping because policy and legislation is trying to prevent you from moving forward, but you are taking the risk to implement, for example, a peer supervised drug consumption, but to make sure people aren't left behind and not, protected from overdose and other things.
Yeah, thank you, John, for introducing this specific issue. So, following the principles of do no harm and left no one behind, and also don't ask for permission, we keep on setting specific services, not only based on the needs of the community, but also the desires of the community. And GAT follows this principle of consulting people use drugs, working with people use drugs. I would say that 80% or 90% of the workers in GAT are peers. Okay, of course, then we have some peers that are also social assistants or social workers. We have some peers that are nurses or doctors. And this peer-led vision of the services changes it all. So GAT opened this drug consumption room. You are specifically speaking in Moraria. That is situated in the heart of Lisbon, in the, let's say, the migrant gentrification, sex work, drug use scene, tourists all over, And one thing, this good relationship with the neighbors, the going also to in the neighbors' assemblies to work with other community, cultural organizations, social organizations around, made this possible to have an officially open drug consumption site that is now official for the first year. So it's open since 2012, and it didn't start as a drug consumption room. It started as a community center, but it was so important to have a safer consumption spot there. Most specifically, we started doing it, peer-led. Let's say first in the toilets because there was nothing else, and then transforming the space in the two different spots, like a drug consumption site and with the supervised smoking room that opened also this year. Before was more informal, like in the open space of the room, but nowadays we have a good smoking room. Let's say good. We fight the medicalization of the services, so we're trying to find it the most designed by the community, for the community, also for the injecting spot. So this is a matter of prioritizing your investments as a community-led organization. This is a matter of getting international funding for making it happen, because GAT in Moraria is the first time that we'll have, I think, national budget. This is a matter of working with peers and address the specificities of people use drugs well-being. So GAT in Moraria is also an hepatitis C decentralized treatment. People can do the safe aid there, can get paid with stipends to get in the medical appointments for hepatitis C. We also have a psychiatrist. You don't need to book in advance. You can just show up 1 or 2 days a week. We have a general medicine appointments also once a week. We have a morning for women on Fridays. We can forward to sexual and reproductive healthcare services and have let's say a free pass for Friday mornings for mostly sex workers and women using drugs. This was inspired in Manas, the collective I found within GAT, and that was always supported by GAT. And even if we are kind of a independent collective of women using drugs and doing sex work, we do a lot of advocacy actions with GAT. We did a conference called We Women Who Use Drugs, We Do Exist, and we do resist as well. So we try to be upfront also in what we communicate in the media, what we point as main factors for our well-being as people use drugs, as women using drugs. We also mention a lot that people coming from prisional settings, hospitals, are the ones more in danger. So our sisters coming from prison settings, sometimes accidents happen because people stay longer, or from you pass 1-2 months in the hospital and you come back to the place where you want to find your friends and get some fun, use some drugs, and things happen because the tolerance is not the same anymore. The drug checking widespread services, it's another thing. We work a lot with Cosmic Care. Cosmic Care goes once a month, even under budget, to the drug consumption sites, but we can always have training, and we call them also for manners, for having, they have a FTIR, that is a good machine for having, moving on apart in the drug scenes to get your drugs test in less than 1 minute. And it doesn't make anything to your drugs. It means that you put it in the machine, the little amount of the substance, and you get it back for you again. And you keep on having at least the ingredients of the, not the quantity, but you have at least a list of the ingredients, let's say, that are part of the psychoactive substance. So we try to push forwards when we don't have a budget from the state, like in the case of Manas, or even the specific program of Cosmic Care to test drugs in drug consumption sites or open drug scenes. We try to get the help of Lisbon municipality to get it funded by our priority programs that are not related to harm reduction. In the case of Manas, are related to gender violence, or in the case of Cosmic Care, to the healthy, let's say, neighborhoods. So yeah, we try to be creative, let's say. We are a lot of creative in generating solutions, and this depends also in the willingness of the people putting forward the advocacy agendas, and mostly not giving up even when you don't have enough resources to get your mission done. If you start and if you prove the efficiency of your projects, then they might become programs. This is the same for naloxone. So we don't have a national take-home naloxone program, but we do teach organizations to have peer-led programs and to get it distributed all over. So I think it's a matter of being creative within the setting you are in.
Thank you so much, Joanna. Honestly, so much that you guys are doing. It's so inspirational, and I think it's interesting here because we do relate in a way, because the drug user movement in Australia, or people use drug, the movement in Australia, was led by also incredible women. So I think there is a really great connection in terms of, like, we know that there's more stigma for women, especially women with children. And that's just so important to acknowledge that, but also to support this energy and this creativity you're talking about. And I know that in Canada, in the United States, amazing queer people as well that are doing incredible harm reduction programs. In Australia, we have like a world-leading network of drug user organization, like community control organization, that are just doing amazing work with, to be honest, very small amount of funding still. Like, I think some of them receive good funding, but I think if they were receiving double, triple, 4 times, it would make such a difference in what they can do, especially because they cover full states. And AVIL does not receive any AOD funding. And there was a report recently that came out that said, in 2022, I think that less than 2% of the AOD funding was going to harm reduction. And that's just unacceptable at this point in time. When you know that there's 6 people a day dying of overdose, and you're not investing in harm reduction, and you're choosing still from a government point of view to invest in policing and treatment. Treatment is important as well, but we definitely want to see harm reduction as a great place to invest. But you're right, we need to be creative. We need to resist the medicalization of those programs, and have incredible peer programs, and prove how those programs change lives and can prevent overdose, so that we can receive great investment. So we need to elevate the voice of people who use drugs, especially in discussion with political leaders. And we have 2 rooms that are medically supervised, but we definitely need more of those peer-led drug consumption room. We need more peer distribution of naloxone, because we know not everyone is going to go to the pharmacy. We also need people to have access from their peers, and from just like other places that they are visiting or using, like community centers and other places. So thank you so much for sharing that, Joanna.
John, I would like just to add, like, for instance, an Ixoy, that is the naloxone we have available here. It costs around $40, a box. So we don't get that money. So it's very important to these medicines to be budgeted by the state, and provision to drug users directly. That means that the state should fund also the participation of the drug users movements.
Yeah.
And this is a participation-led fund that we do not have it, like, again, nationally implemented here, but we do strive for having it as a, we call it like a peer low threshold employment grants. And employment in terms of participation, in terms of advocacy, in terms of implementation of service-led, like this peer-to-peer naloxone distribution program. So I think just to finish, I would like to end up saying that please budget naloxone, like, nationally.
Absolutely. Thank you so much, Joanna. I don't know if we still have Sione with us, but I would like to ask Sione kind of in closing how what would you like to see, as a director of ABLE, as a CEO of one of our member organization? I know it's a big question, but
What would you like to see happen in Australia to make a difference to prevent overdose, but also to support our community?
It is a big question. So I guess there's a couple of answers. One would be like something practical that's related to the stuff we're talking about, naloxone and kind of immediate overdose kind of responses. I think that more smaller peer-led injecting rooms and or drug consumption rooms, I should say, all over the place. That's very unlikely to happen in the short term, but that's probably one of the things we need. The other thing is like I don't think that I don't necessarily mean that we need a technological solution for this, but we need to come up with some solutions which will probably involve technology, whether it's phones or apps or automated kind of responses. But we really need to get to grips with the fact that many and most overdoses occur with people using alone. So on the local level, it's about trying to eliminate that, or to respond to that in a way like allow people to have I don't necessarily think a phone line's the way to go, but some way to connect peers and networks of people so that people are able to use alone and be connected to people safely at the same time, so that if they don't get a response, there's a way to for people to help. But really, like I said in the presentation, it's about destigmatizing drug use and people who inject drugs and use drugs, in particular opioids in this instance mainly. But there are other ways of overdosing as well. And so we need to continue to kind of train people in overdose response that isn't just about naloxone. So you can keep people alive for some time when they overdose on opioids, but also you can respond in different ways to other overdoses. But the only way we're really going to destigmatize this is if we decriminalize drugs and ideally legalize them. But that's a whole nother conversation. It will probably take a while, but that's probably what's at one of the big structural things that are at the root of this. But I think there are still some things that we can do to support people who are using alone. I don't have all the answers, but I think that's probably one of the things we need to do to get the overdose rates down. Because obviously, if you're by yourself, you can't use naloxone on yourself if you've overdosed. Nitazines and fentanyl and high potent synthetic opioids is another kind of wrinkle in this, but really it's the same responses, but with higher acuity and kind of quicker responses. And there was a question in the webinar chat about Nixoid and synthetic opioids. I don't think that the nitazines have spread so much that we sort of need to change Nixoid immediately. I'd be really a bit worried. I don't necessarily want Nixoid to be stronger at the moment, because it seems to be not a bad. It's not. We don't want people to be coming out of overdose hanging out. So I think it's been titrated quite well. But there are things like prenoxide and ampules as well if people need to use more.
Thank you so much, Sione. That's a good point about people using alone, to make sure that people have access to peer support. And I think it's important to look at as well what happened in WA with, the police carrying naloxone that Paul presented in one of our other webinars, to make sure that, the first people on site have naloxone available as well. And for people
in the room that don't know, like naloxone, there's no contraindication of using naloxone. You can use it multiple times on someone. If someone isn't, you don't know, but if someone isn't overdosing because of opioids and you give them naloxone, there's no problem there. It is better safe than sorry, I guess, on that one. And that's a good point around the spray. I think sometimes people use the first one as like a test, and then there's a bit of an issue. But the most important thing is to have strong dose and availability of naloxone. Thank you so much, everyone, for sharing your expertise on this. I think today we really wanted to make sure to honor the people that we lost to overdose and the incredible peers and people with lived experience that are still with us and that are making a difference every day and using naloxone, and ensuring that policy is changing and that the Commonwealth and other states are investing in peer-led response and other responses. So I hope we honored people today. Thank you so much for joining us and taking the time. Thank you, Sione. Thank you, Joanna. Thank you, Colleen. It's really appreciated. You guys are amazing. And thank you for your amazing work and joining us today. Have an amazing rest of your day, everyone. Thank you so much.